Okay, cool. Right. So yeah, I'm going to talk about my project on simulation modelling of the pediatric critical care system in the southwest of England. So just a quick bit of background that formed the basis of the project idea. In November 2019, the Pediatric Critical Care and Surgery in Children Review was published. Within it, it proposed 3 new tiers of pediatric critical care. So level 1, which is high dependency, level 2, which is specialist high dependency, so slightly more specialist care, and level 3, which is intensive care. It also recommended bringing care closer to home by means of bringing the level 2 units more geographically closer to home. And it also tasked the operational delivery networks, or ODNs, with designing the configuration of this new system for the regions that they cover. So the current situation in the southwest is that we've got 1 pediatric intensive care unit, or a level 3 unit in Bristol, and also a specialist high dependency or level 2 unit within Bristol as well. But we also have 7 high dependency or level 1 units in the southwest outside of Bristol. So the problem is, and then what the project was trying to kind of answer, is where to locate a level 2 unit or units outside of Bristol. So bringing that care closer to home geographically. So the methods that I used to tackle this problem within the project were geographical modelling and discrete event simulation. I'll talk about each in turn over the course of the presentation. But just to say a little bit about the data sources, because the project took a lot of time data churning and sourcing the data. So I thought I'd speak a little bit about that. So I pulled data for the calendar years of 2017 to 2019. And I pulled data from the Pediatric Critical Care Minimum Data Set, which is held within the Secondary Uses Service, or SAS. And this SAS data are used to define the level of care through the health resource groups, or HRGs. However, it was incomplete for a lot of the providers, with the exception of the Bristol Children's Hospital, Gloucester and Plymouth. I also used the Southwest Audit of Critically Ill Children, which is held by the Southwest Pediatric Critical Care ODN. It was more complete, but it took time to define the levels of care within the data set, as it didn't contain any HRG coding. And so I combined that data sets together to provide a more robust data set, which I've used as the basis for the modelling. So once I got over that kind of step and I got all my data together, the next challenge was defining geographically where patients were coming from across the combined data sets. And I eventually pinpointed this to the postcode area, as it was present in both data sets. I was then able to source the shortest distance to each hospital in the southwest from the postcode areas, and use this to define the patient's local hospitals, the closest hospital to where they kind of live. I then used a package called GeoPandas within Python to visualize the analysis on geographical maps. And again, this wasn't a quick and easy process, as it took time to locate the correct polygons, which is the shapes that are put on the map to represent the postcode areas. But once I got over that kind of hurdle and I was able to get past that, I was able to produce the following maps and visuals. So this first one is a map of the level 2 pediatric critical care stays in the southwest by postcode district or postcode area. And as you can see, the Bristol Royal Hospital for Children, which is the level 2 unit, the specialist high dependency unit in the southwest, is represented by this star here in the more sort of northerly area of the southwest. And as you can see, there's quite a large distance to sort of travel from the southerly parts of the region to receive that level 2 critical care. that level 2 critical care. And so I think this kind of demonstrates the inequality in terms of geographical access to that level 2 care quite well. And even more so in this chart, or this map rather, which shows the level 2 critical care stays where patients have had to travel to their non-local hospital to receive that care. This is more likely going to be the Bristol Royal Hospital for Children as the level 2 unit in the southwest. And as you can see, the darker kind of colours, which is the higher volumes in comparison to the other areas. There's quite a lot in the kind of the southerly part. So again, that kind of demonstrates quite well the need for a level 2 unit outside of Bristol. But where to locate that unit outside of Bristol? So in order to try and address that question, I developed a discrete event simulation model to try and scenario test where best to place that unit outside of Bristol. So I built what they call an object-oriented model using a package within Python called SymPy. And this is the kind of concept diagram or concept model of that simulation model. So just running through it. So the model generates patients at the very start based on randomly sampling from a distribution with an inter-arrival time. And then the patient's assigned an initial level of care, so whether that's level 1, level 2 or 3. They have a length of stay assigned to them, which is kind of unusual for a patient to know how long they're going to stay in hospital, but for the purposes of the simulation model, that needs to be defined at the beginning. Their local hospitals is also assigned to them, and that they carry through those kind of values through the model as they travel through. So they're then admitted to their local hospital. However, each hospital within the model in the southwest has a highest level of care assigned to it in which they can accept. So if the patient has an initial level of care of level 2, let's say, but their local hospital has a highest level of care of level 1, then they will have to be diverted to the closest level 2 unit and not admitted to their local hospital. But once they're admitted, to simplify the model, because it was becoming quite complex as I was building it, a patient can only step down 2 times from their initial level of care. So if they come in at level 2, let's say, they can only step down to level 1, they cannot go up to level 3. Looking at the baseline data, that combined data set, only a small percentage of patients actually stepped up in care. So it was felt that it was a fair assumption or fair simplification of the model to just have step downs in the model. So once they've completed their length of stay, they're then discharged or transferred out of critical care. So in terms of scenario testing, this highest level of care assigned to the hospital units in the southwest can be changed in terms of the simulation modelling, and that once you change it, you can then run the model and see whether the level 2 unit that you've assigned generates sort of better sort of outputs. And those outputs from the simulation model were the number of patients that have gone through the simulation modeling. So I ran the simulation model over a 365 days, a 12-month period, obviously not in real time, but in terms of the model. And so the outputs are the number of patients that have gone through that simulation model, their levels of care, the number of bed days that they've generated, the average number of nurses required in each unit, the proportion of time patients cared for away from their closest hospital or local hospital, and the average distance from home location to treating hospital. So just looking at that average distance from home location to treating hospital, I've generated these baseline results for a comparison to the results from the simulation model, and running it without anything changing. The results were very comparable, so I was happy that the simulation model was demonstrating well, at least showing the same results as the baseline. And And as you can see from this chart, so it's looking at the level 2 critical care stays with looking at the average distance that a patient would travel from their local hospital to a treating hospital. And so in a sense, these are the catchment areas for the hospitals. And as you can see, the level 2 unit, so UH Bristol is the host trust of the Children's Hospital level 2 unit. So their average distance travelled for patients is quite low in comparison to Royal Cornwall, which is very high, which is the most southerly point of the southwest. But what if we located the level 2 unit as well as Bristol in Plymouth? And so I ran a simulation model to see what impact that would have. And this is the results. And as you can see, Plymouth has a comparable average distance to treating hospital to Bristol in this simulation. And Royal Cornwall's average distance is reduced as well as a lot of the other sort of Devon providers in the southerly part of the southwest. So in terms of the impact of the project and the programme, it provides, and certainly in terms of the geographical modelling, some visual evidence to suggest the need for a level 2 unit outside Bristol. The simulation modelling is providing a means to test the models of care with a view of bringing that care closer to home. And in combining those two, it will help to inform commissioning decisions on the location of the level 2 units and sort of inform and help the Southwest Pediatric Critical Care ADN in their recommendations for where a level 2 unit will be located. So just some reflections on the HSMA programme as a whole. I find it personally challenging, but very rewarding. So learning some quite complex modelling techniques, for example, the object-orientated programming, with concepts that took some time to get my head around. But once I figured it out, it was very rewarding with a sort of a great sense of achievement when applying it to this project, at least. And in terms of training, I find it very engaging with the healthcare-related examples. I've been on past training courses where I spent a lot of time after the training course trying to figure out how to apply this to the real world problems in healthcare, where it's all done for you in the HSMA program. And certainly the project has given me an opportunity to apply that kind of learning as well in a real sort of real world problem. So the skills gained are becoming very important, especially within commissioning, where it's important to have robust analytical evidence to support development of new services or models of care. And so I would thoroughly recommend the HSMA programme to any analyst who would like to learn these important skills. And for me, I don't want the learning curve to end, so I applied for the trainee mentor scheme, which I've been successful, and so we'll continue that sort of learning curve from the programme, which I find very rewarding. And that concludes my presentation.